Thank you. And dear Dr. Means and my colleague, good morning. The topic of my presentation is it time to treat patient with erosion medically, or is it time for a randomized trial? So first, what is the implication of the distinguished plug erosion from a rupture? This is, we have the 28-year-old man presented with STEMI. Left side, so the patient have no other traditional risk factor except smoking. And index angio show total occluded almost proximal to LAD, and after thrombus aspiration, the antegrade flow restored and free, and there's a very mild stenosis in proximal LAD, and other vessels circumflex right coronary is completely normal. So what is the mechanism for this younger, very young gentleman presented with STEMI? So from autopsy study, we know most common cause is plug rupture followed by plug erosion, about 1/3 of patient, and less than 10% of patient may be caused by calcified nodule. And here we have high resolution intravascular OCT can in vivo diagnosis plug rupture, erosion, calcified nodule dissection at the time of primary PCI in a cath lab. But so from clinically inside point, patient with plug erosion is younger and more smoker, had less traditional cardiovascular risk factor, including hypertension, diabetes, compared patient caused by rupture. And the patient with erosion caused more often presented with non-STEMI, and thrombus is almost lipid white thrombus, and less severity of stenosis compared rupture. And also, patient caused by plug erosion presented with STEMI responds differently to the antithrombotic therapy, especially lytic therapy. Implicated eroded lesion respond better to antithrombotic therapy, and also stent implantation. So it's 1 month OCT follow-up shows the less favorable intimal healing in the patient with plug erosion with the stent implantation. So from pathological study and also imaging study, plug erosion is fundamentally different from rupture plaque. Plug erosion is most, I think, significant difference in intact fibrous cap, less natural cold, lip-rich, platelet-rich white thrombus. The patient is younger, present more non-STEMI. So I think the ACS patient caused plug erosion without obstructive stenosis could be treated with medical therapy. So how to treat the patient caused by non-obstructive plug erosion? Here's the concept of the erosion study. So, if the ACS patient caused by plug erosion with a non-obstructive reader stenosis and antegrade blood flow restored, probably those patients can be treated with antithrombotic therapy without the stent. And I think as long as the lumen preserved and no thrombus formed, the patient can be fine. So here is the first case report. We had a 60-year-old gentleman presented with STEMI, and index angio showed distal right coronary total occluded, and after thrombus aspiration, antegrade flow restored, and without any sign of a plug rupture. And at 3 months up to 6 months follow-up, the patient have no symptoms of the ischemia. And this, I think, the first case report we reported in JACC cardiovascular intervention shows probably patient with plug erosion can be treated medically guided by OCT. But this is such a case. I think it's not. It's time to change our practice. We know, so we need high-level evidence for this new strategy, like course control study, case control, or a randomized trial. So that that's why we came up the erosion study to try to validate a non-standing strategy for this subgroup of patients with caused by non-obstructive plaque erosion. So it is a single-center study, observational study, a kind of a pilot study to include all the patients present with almost 95% patient present with STEMI after primary PCI with thrombus separation or thrombolysis. The antegrade flow restored. If the angio show the diameter stenosis less than 70%, the patient will be treated medically and will be followed by OCT at 1 month and 1 year. And the right figure show that 1 month with anti-thrombotic therapy with the thrombus volume decreased and the minimal lumen diameter increased. This is the hypothesis of this trial. And also we can see at 1 month and 1 year thrombus burden decreased significantly and gradually up to 1 year. Here we had a 37-year-old gentleman presented with STEMI, and index angio, so total occlusion at the side of the diagonal. And after thrombus aspiration, we performed OCT, so high suspect of the plaque erosion at 1. The patient was treated medically, and we followed patient with OCT at 1 month and 12 months. So from the angio, from the OCT, so very favorable response result, and also patient is asymptomatic. Here's in the consensus ESP consensus document of the imaging guidance in ACS patient. So, for the patient caused by plaque erosion without obstructive lesion and antegrade flow restored, conservative treatment might be can be considered, but need further evidence. Here's a similar case, and also we followed patient up to 5 years, and 80% patient still did well and were treated medically. So how about patient with caused by non-obstructive plaque rupture? That why we did this Erosion 2 trial to test whether OCT-guided non-standing strategy could be possible in patient with plaque rupture. Here's a study. This is a prospective multi-center observational study. The primary endpoint is similar in Erosion 1 study. That is 50% thrombus burden reduction at 1 month. Here the study flow chart, we included over 347 patients presented with STEMI, including 152 patients caused by rupture, almost 200 with plaque erosion. We followed patient at 1 month use OCT and angio. Here's a primary endpoint, and almost we targeted primary endpoint, and more than 80% of patient thrombus burden reduction is more than 50%. It's also similar between the rupture erosion. That show with anti-thrombus therapy at least at 1 month, OCT results so favorable response to those both rupture and erosion without obstructive disease. But it's still like randomized trial for the implication of the conservative treatment for patients with plaque erosion. So the Erosions 3 trial is a randomized trial to compare OCT-guided versus angio-guided in patients with presented with STEMI without obstructive disease. Here the study design, the patient presented with STEMI on plan for primary PCI. In OCT-guided group, its OCT show non-obstructive plaque erosion, scattered spasm, or rupture without dissection. The medical therapy will be considered. In angio group, the patient will be treated and center of care. This is a study flow chart with 246 patients enrolled and randomized 2 groups. This is a primary endpoint and main finding. So in OCT guided group, 44% patients were treated by stent implantation, and more than 50% treated medically, compared to 60% patient treated with stent in angio guided group. That's it, a 15% reduction of the stent implantation guided by OCT. This is a subgroup of the patient. Of course, the sample size is not powered for clinical safety endpoint, but at 1 month, so almost similar between the 2 groups. So the conclusion of this study in selected STEMI patient without obstructive disease, OCT guidance compared to angio-only guidance can reduce stent implantation during primary PCI, and also could be considered for decision making in optimizing the perfusion strategy. But still, the safety and cost effectiveness merit further assessment in larger randomized trial with a longer follow-up. So we did a sub-analysis for this Erosions 3 trial and showed the benefit of OCT-based reperfusion strategy in STEMI at 1 year's angio follow-up. The 57 patient in angio group and an OCT group received angio follow-up at 1 year, and so the OCT guided was associated favorable late lumen loss and similar 1 year angiographic outcome even with less stenting at baseline. So what we learned from not only Erosions 3 and Erosions 2, so the imaging-based morphology guided PCI probably is the call for precision medicine. So the patient, especially present with STEMI without obstructive coronary artery disease, intravascular imaging guidance can be change the strategy of those patients. So the patient with a scant spasm, non-obstructive plaque erosion, or rupture could be treated with medical therapy only. So here's from the definition of the OCT diagnosis of plaque erosion from 2013 and until now. We did several retrospectives, perspectives from single center to multi-center, from observational study to randomized trial. I think the question is it time to treat patient with erosion medically? I would say yes, but probably we need future randomized trial to validate the effectiveness of this non-stenting versus stenting strategy on long-term clinical outcome. Thank you very much.